Mr. Gomez is a 56-year-old man who works full-time as a speech pathologist. He presented to his primary care physician 1 week ago with abdominal fullness, left upper quadrant pain, weakness, and fatigue. His past medical history includes hypertension, which has been well controlled on hydrochlorothiazide. A chemistry profile and complete blood count were obtained. The chemistry profile was within normal limits, with an exception of an elevated lactate dehydrogenase, LDH. The CBC revealed a white blood cell count of 125,000, hemoglobin of 10.5, a platelet count of 600,000, and 2% peripheral blasts. Physical examination revealed palpable splenomegaly 10 centimeters below the costal margin. Mr. Gomez was referred to a hematologist-oncologist for an evaluation which included a history and physical examination, CBC with differential and peripheral blood smear review, and a bone marrow aspirate and biopsy for morphologic review, percent blasts, basophils, cytogenetics, fluorescence in situ hybridization, or FISH, and quantitative polymerase chain reaction, commonly referred to as qPCR, to detect the BCR-ABL fusion gene. Mr. Gomez was given hydroxyurea while diagnostic results were pending. He was instructed to start allopurinol and increase his fluid intake to 2 liters of non-caffeinated beverages a day for tumor lysis prevention. Mr. Gomez returned to the hematology-oncology office today to discuss the results of his diagnostic evaluation. He was told he has chronic phase chronic myelogenous leukemia and is now meeting with the nurse practitioner to discuss his treatment in further detail.
You'll be taking 1 tablet of imatinib, 400 milligrams daily, and it should be taken every day at the same time with food and a large glass of water. Over the next few weeks, I'd like to see you in the office more frequently so that we can monitor your blood counts more closely. A drop in the white blood cell count and platelet count is expected, but you should still be able to take your medication daily. You may develop some side effects while taking imatinib. Most are mild, easily managed, and will improve with time. Some of the most common side effects include nausea, vomiting, diarrhea, rash, swelling, abdominal pain, muscle cramps, headaches, and fatigue. But you may or may not experience any of these. There are also some rare but potentially serious side effects that are commonly seen during the first few weeks of treatment, and we would like for you to call in immediately if you experience a fever greater than 100.5 degrees Fahrenheit, shaking chills, bleeding, rapid weight gain over a few days, chest pains, shortness of breath, or difficulty in urinating. But what's most important is that you record and report any side effects you experience.
What should I do if I forget to take my medication?
That's a very good question. If you forget your dose, you should take it immediately unless it's within 12 hours of your next dose.
Can I take imatinib with my blood pressure medication?
It's best to take it at a different time than your hydrochlorothiazide or other medications because imatinib can interact with over-the-counter drugs or herbal medicines. So if you're planning to take either, please let us know so that we can avoid any possible reaction.
The NP continues the education session with Mr. Gomez and provides written materials to reinforce understanding of the disease process, medication regimen, and potential side effects. The NP also provides contact information for advocacy groups for financial and emotional support. Mr. Gomez will be monitored weekly for 1 month, then every 2 weeks during the 2nd month for a physical exam and laboratory testing to monitor treatment-related side effects and response.
Good morning, Mr. Gomez. How are you feeling this week?
Morning. Not so good, actually. I've been nauseous the last 2 days.
Have you been vomiting?
No.
How have you been taking the imatinib?
I'm taking it at bedtime with a large glass of water.
Taking it at dinner time may reduce the nausea, but I'll prescribe an anti-nausea medication for you, just in case that taking it with food doesn't help you. Oh, and I have good news for you today. Your white blood cell and platelet counts have improved since starting treatment, and your other lab results look good today. So we'll continue to monitor your blood counts regularly to make sure that there are no problems.
Mr. Gomez calls the office with complaints of shortness of breath on exertion. He is instructed to report to the hematology-oncology office immediately for an evaluation.
Mr. Gomez, I've noticed that you've gained 6 pounds. since I saw you last 10 days ago. I noticed that your feet are swollen, and I'm concerned about the fluid in your lungs, which is making it hard for you to breathe. So I'm going to order a chest x-ray, and then I'd like to see you again after the chest x-ray.
Mr. Gomez is diagnosed with a right lower lobe pleural effusion. He is placed on diuretics and his imatinib is withheld. His symptoms of shortness of breath and lower extremity edema improve over the next 4 to 5 days. Mr. Gomez is seen 10 days later with complete resolution of the pleural effusion. The imatinib is restarted. Although rare, fluid retention is an adverse event related to imatinib therapy. It's important for oncology nurses to monitor for fluid retention events in patients with CML and to educate patients on the signs of fluid retention. 3 months after starting imatinib, Mr. Gomez's response to therapy is evaluated. A CBC reveals a white blood cell count of 25,000, hemoglobin of 11.9, and a platelet count of 550,000. It appears that he is not in a hematologic remission. A bone marrow biopsy is performed with cytogenetics, FISH, and qPCR to further evaluate his treatment response.
So, Mr. Gomez, how are you doing?
Well, I'm really anxious to know about my test results, and I want to know how well I'm responding to the therapy.
We do have your test results, and unfortunately, you're not responding as well as we'd like you to. Given your difficulty with fluid retention, it may be difficult for you to tolerate a higher dosage of imatinib. But there are 2 other medications that are for patients that are no longer benefiting from imatinib, nilotinib and dasatinib. Nilotinib is less likely to cause fluid retention, and that would be the better choice for you.
The NP continues to educate Mr. Gomez on the role of secondary tyrosine kinase inhibitors, also known as TKIs, which include nilotinib and dasatinib. He was started on nilotinib 400 milligrams orally twice daily. A thorough medication history should be obtained prior to starting nilotinib to identify whether the patient is taking any CYP3A4 inhibitors or inducers, as they can affect the serum concentration of the agent. Prior to Mr. Gomez initiating therapy with a secondary TKI, a baseline CBC chemistry panel and electrocardiogram are obtained. Monitoring of electrolytes is critical for patients receiving nilotinib due to the rare adverse event of QT prolongation. Hypokalemia and hypomagnesemia should be corrected to decrease the risk of QT prolongation prior to starting therapy and throughout the treatment trajectory. EKGs are obtained to monitor the QT interval at baseline, 7 days after starting therapy, and then periodically at the discretion of the healthcare provider. During the first month of therapy, he has no EKG or laboratory abnormalities. Mr. Gomez returns to the clinic for follow-up 4 weeks after starting the nilotinib.
Mr. Gomez, your white blood cells have continued to drop, in particular your neutrophils, which increases your risk of infection. Have you experienced any fevers or chills?
No fevers or chills.
Good. We need to temporarily stop the nilotinib and have you return to the office in 4 days to repeat your blood work. The temporary discontinuation of the medication will most likely allow for your white blood cells to recover, and then we'll be able to restart therapy. If you develop a fever of 100.5 or above, or show signs of infection, it's critical that you call our office immediately.
The NP continues educating Mr. Gomez about the signs and symptoms of infection and protective measures to decrease the risk for infection. He returns to the office 4 days later for a CBC check, and his neutrophils have recovered to 1.7. The same dose of nilotinib 400 milligrams twice daily is restarted. Mr. Gomez is currently in a hematologic remission. He will have additional testing performed at 6, 12, and 18 months from therapy initiation to evaluate his cytogenetic and molecular response to nilotinib. The nurse practitioner played a key role in the success of Mr. Gomez's therapy. Oncology nurses must be prepared to optimally care for patients with CML, advocating for patients to receive the latest recommended treatments, educating patients on their treatment course and potential side effects, monitoring treatment responses, and managing any complications that occur throughout the treatment trajectory.